recording it. Okay. So thank you very much. We are going now to start this webinar. We are going to talk today about immediate post-extraction implant and the key to success. This webinar is managed by Dr. Laurent Bluche from France. Dr. Bluche is degreed in Montpellier in France. See, please silence your microphones, please.
Switch off.
Yes. Please switch off your microphones when entering. Dr. Bluche is an expert in implantology, is degreed in Montpellier in France, but he's also master in anatomopathology in Montpellier School of Medicine. He's also certificate on advanced graduate study in the Graduate Dental Medicine Boston in USA. Also assistant professor in Montpellier Dental School. He's advanced graduate study in implantology in Toulouse Dental School. He's also assistant, sorry, because please switch off microphones, thank you. He's also assistant professor in implantology in Toulouse in the program of implantology. And also he has written many articles, international documentation, clinical studies, and is founder of the scientific association in France as well. So I think it's a good opportunity for us to learn from him. Please, I suggest this, please switch off your microphones, keep them silent, and I suggest you write your questions in the chat, and I will transmit your questions to Dr. Bluche when at the end of the meeting. Okay? Thank you.
First of all, good morning or good afternoon, depending upon. I'm very pleased to talk to you in India. First, because a part of my family have a great history with India. One of my ancestor, I will switch to the next, I cannot, wrote a book, the Kara Sankalita, was named John Warren. Also, I learned a lot about India by my ancestors, and I'm very pleased to talk today about immediate post-extractional implants. I'm doing all this procedure for now 27 years. My first post-extractional immediate implant was around in 1997. And I found out all around the world, the years, that a part of the immediate implant is 3 parts very important. We are doing post-extractional because of the gain of time. I mean, it's quicker than extract the tooth, wait for the healing, and after place the implant, waiting 3 months. 3 months or 2 months, depending upon. The morbidity is decreasing. I mean, we have less problem when we're doing a post-extractional implants, and it's maintaining the hard and the soft tissue. And for the aesthetic purpose, this is great because we just avoid shrinkage of the gum and to have the loss of the all around the implants, all around the tooth too. Also, the fact is we're using post-extractional a lot, and my main practice is about post-extractional implants. And I found it successful because, I mean, we just freeze basically all the landmarks of the gum and the bone at the state that it is when you begin. And you will have a nicer aesthetic when you use post-extractional implants. I'm getting to the next, but I don't think that, no, the next, that's it. I don't know, if some stuff on the screen, I cannot remove it and I don't know why. I will check if I can. Here we go. And now you don't have the stuff in the screen. Also, the main point of view when you're talking, one more time, I have stuff on the screen. I will remove it. Just here we go, done. All right. The main purpose when you're talking about post-extractional implants is three spots that you have to talk about. Is basically the soft tissue, the pink stuff, and the hard tissue. The hard tissue help you for the osseointegration and the primary stability at the beginning. The soft tissue will be the gain in time. That means that your long-lasting implant will long last because of the soft tissue. And the balance between the angle of the ridge and the prosthetic work has been to take in consideration, because I mean, when you have a very angulated ridge, you cannot have screw retain, direct screw retain prosthetics. Also, we have to take in consideration the three together to have something that works. One more time, I have to go to the next. The soft tissue give you the long-lasting stuff. I mean, this is the main purpose, is why a lot of periodontists are also implantologists, because you have a long-lasting, when you have attached gingiva, when you have the thickness of your connective tissue, your implants will be well integrated in the mouth, and you will have a nice aesthetic that will last. The hard tissue give you the primary stability, and the primary stability is a mistake, is a mistaping, is stability, not stability. Stability give you the osseointegration, and this is important when you are doing post-extractional implant. Basically, you are looking for a primary stability first, and after you are looking for the rest of it. Also, primary stability gives you the osseointegration, and also is maintaining the pink. Also, one is under the work of the other. When you have the pink, you will have both the pink and the yellow. Like that, you will have the main aesthetic and the long-lasting implant. And you have to have an harmony, a balance between the prosthetic axis and the implant axis. That means that sometime when the teeth, the ridge is too angulated, is no way that you get into a screw retain. If not, you will break the buccal area. Also, sometimes you have to have a double type of prosthetic. You have to have the abutment, and the abutment will be you will cement the stuff on the abutment. But I mean, mainly we try to have screw retain procedure. The essential elements are the treatment planning. It means that to get a post-extractional implant, you have to have the primary stability. That means that you have to have enough bone to be able to place your implant in the native bone. This is really important. Over the years, I found out that you place the implant usually in palatal area. When you're in the maxillary, you place in the palatal area. Like that, you get your implant in the native bone. And Dr. Salah Uez, which is a periodontist from United States, developed a treatment and drills to be able to increase the size of your native bone. Is called osteodensification, and this is the group Versa who are doing that. And like that, you can have your implant in the native bone, and you yep. Yes. Okay. You can have your implant in a native bone, and you basically graft to maintain your native bone. But when you place your implant in the native bone, you basically maintain your implant in the good biology. and in the biology of the patient, and you're not placing in the graft, and it's long lasting when you place in native bone. Also in post-extractional, immediate post-extractional implants, the best thing is to place in a native bone, is give you the primary stability, and you increase the bone by grafting. And when you graft, basically you maintain your native bone, and also you maintain your biology. Also, you have the gum volume. Oftentimes in the anterior area, you better to either do partial extraction. That means that you leave a part of the root in the buccal area or for the maxillary, and you basically, if you do not have that, basically what you do is a connective tissue graft to be able to increase the volume of your gum. And also is a prosthetic treatment. Basically, it's the beginning to begin with. It's a prosthetic treatment, and implantology is a surgical part of a prosthetic treatment. Also, the prosthetic is the one where the chief of the procedure, and the prosthetic give you the idea where you will place where you will place your implant. Let's see. I want to do okay. So basically, you're getting from the primary stability when you place your implant to a secondary stability where you have your osseointegration. And I found out by using osseodensification, driven by Versa drills, you basically have a stability from the primary to the secondary stability for different reasons, and I'm not talking about that today. But you keep your implants in the native bone and your graft to maintain your native bone. That means that you will be on the upper more palatal, like that you will have a screw retain easier prosthetics. And in the same time, you place in the socket beta TCP, whatever graft you want to use. Usually is a resorbable graft that you place to maintain your native bone. What I will explain you through a first clinical case, also post-extractional on the lateral incisor. The lateral incisor was broken, and you see that we have the tooth is buccally placed like usual because sometimes, I mean, oftentimes the tooth is in the buccal area. So what we're gonna do is just getting into the palatal area and basically osseo-densify the palatal area to be able to place the implant in the native bone. Let's see the next. Like that, you see in the buccal, we missed the buccal plate. So what we're gonna do is using Versa for osseo-densification. I'm sorry, this is written in French. Is increasing the primary stability, and also you have an expansion of the bone. Like that, you will have native bone all around your implant, and you will here I place GMI implants on this lateral incisor is 3.75 avant-garde, and I will add. I always check the ISQ for the immediate loading. When it's inferior to 70, I will not load the implant, even in temporary. So this is something that you have to use because it's really predictable. If your implant is stable, you will have osseointegration. Even you place a temporary on the top of it. Also, this is important. It's important to check it, and it's important to record it. Next one. And as I told you, you have the hard tissue and you have the soft tissue. Basically, you took care of the hard tissue because you place your implant and you place your implant. I hear something. Can you switch off your microphone, please? Thank you. And you add a connective tissue that you take from the tuberosity. Tuberosity, you always have a lot of connective tissue. And basically, I place tunnelization in the area, in the buccal area, as you see it here. Also, you will have in the buccal area the placement of the connective tissue. Like that, you will have the pink and you will have the yellow all together. And basically, you get into the sex, you will access to the sexes because you have all the spot just placed in together. Next one, let's see. After that, I place the implant in a native bone and I graft to maintain the native bone in the same time. And like that, I will place a resorbable beta TCP from GMI. It's called Iceberg beta TCP. Like that, I will maintain my socket in the same time. And as as you can see on the lower left, you will have the healing after 1 week, 10 days, and you see the bulk of the connective tissue that is growing, because basically from the tuberosity, it's always growing when you place it. And this is great. It's why I like better to take it from the tuberosity. You have a periodontist called Ricardo Kern. He's English. And is using all the time connective tissue from the tuberosity because it's a very reliable connective tissue. It doesn't bend cake, and it's still a great material to use, and the material of the patient, basically. After 3 months, we retake the ISQ. It's 75. And like that, you still have the temporary, it's just holding a bit, but you can see the emergence profile on the lower left, where you have the good emergence profile for crown that we will place. So we take the impression, and I will place high polished zirconium for all the stuff that is transmucosal, because it's nicer for the gum, and an IMAX on the top of it to be able to get something nice and a good aesthetic and a good translucency. And as we can see, the harmony between the prosthetic and the axis of the implant is great. Also, we can screw retain it. As you see, the emergence profile on the upper left, and you have the final restoration on the lower left and lower right. And the good thing to talk about is when you have the contact point, which is at the crest plus less than 5 millimeter, when the contact points touch less than 5 millimeter from the bone crest, you will have a papilla. The papilla will regrow, always. Also, I send the X-ray to my technician, and the technician places the contact point less than 5 millimeter from the bone level, and like that, I will have my my papilla back. Next. Another case from the central incisor and a broken tooth. So we will do the same, and you see the tooth is buccally placed in the same time like usual, but I still have something in the palatal area. Also, I will densify the bone, but you see, and I come in reverse, the angulation of the ridge is not good to be able to have a screw retained prosthesis, because if you place your implant, you will get into the buccal area, and basically your implant will go through the buccal bone. Also, what I decide to do is to have a cemented crown, and having an abutment made in zirconium, and on the top of it a full ceramic crown. Also, I did decide it just right away before getting into the surgery. As you see, the tooth 21 is just buccally placed. We have also a problem of space. Also, we have to complete the treatment by placing a veneer on the other central incisor to be able to manage the difference of the size between the two teeth, and getting into the palatal area to be able to
Recording in
One second, please. Please,
Okay.
I really strong please switch off your microphones. There is a lot of confusion. Thank you.
Thank you. So what I'm doing is just I'm placing, like usual, the implant into the palatal area, also densify the bone to be able to place the implants in the native bone. I will graft with beta TCP all the socket, and in the same time I will add connective tissue to be able to increase the pink. Also, as you see, I'm pretty much in the area of the buccal, but I cannot go to buccal because I still have a curve in the apex area. Also, if I do that, I will make a window into the bone, and I do not want to do that. I'm taking the ISQ always, and like that, it has to be over 70 to be able to place a crown on it. After that, from the tuberosity, I'm getting some connective tissue that I place in the same time. So the surgery can be done everything together. I did have a temporary with 2 wings, because if I do not have the primary stability, I can glue the wings to the other teeth, and like that I have a glue temporary on the other teeth. I take it on the peak abutment, and I place the temporary crown shorter and a bit wider because I didn't manage the space on the other tooth for the time of osseointegration. After 2 months, you see the gain that we have. The implant is getting in slowly. And after 3 months, sorry, we have the bed of the emergence profile of the future crown. And we take the second ISQ to be able to see that the implant is also integrated. And when it's green, it is okay, 75. Also, everything is good, everything together, everything is fine. We take the emergence profile with a flow composite. And we take the impression like usual, but I mean, not could be in 3D, but this is the usual with the putty and the light mixed together. And we have the final restoration for the patient with the veneers in one side and the prosthetic work glued to the cemented to an abutment in zirconium. The abutment is in zirconium, and at the top is an IMAX that I place in, and the veneer is IMAX 2. Also, the main purpose is maintain the native bone and place the implant in the native bone. Native bone is what you have to share and to be able to maintain, because when you have you implant in the native bone, you have a biology is maintained. This is very important. And also you have to increase the soft tissue to be able to maintain in the area of the emergence of your implant. Also maintain it and place it when it's anterior teeth. You have to place connective tissue to be able to maintain everything together. Another case post-extractional, as you see, that is an apicoectomy. We didn't work well. Also, we obliged to remove the tooth and remove the cyst. This is just on the top of it. And what I could do is, after I did remove the cyst, when you see from the left to the right, still removing, it's just coming off on the upper right. And the left is the beginning, also left, lower left, and after you have upper left, after you have upper right, after you have the bridge of the bone that I maintain because it's thick enough. If your bone have a thickness enough thickness, and if you have, I will place it here, more than 2 millimeters of bone here. Oops. If you have more than 2 millimeters of bone, you can maintain it. If you have less, you have to remove it because, I mean, the body will think that is a piece of bone remaining there and will remove it with your graft in the same time. Also, you have to maintain it when it's thick enough. That's it. That's what I said. Also, next one. Let's see. Okay, let me push in here. I'm doing a groove in the palatal area to be able to have the primary stability, and I'm taking 1 or 2 millimeters in an apical area to be able to have the primary stability good together. And like that, I will have my implant placed in most of the native tissue that I can, and I will graft the rest of it. Here you see how I place the implant and the little bridge that I maintain to be able to place my graft, Beta TCP from GMI. And on this one, I didn't do a loading, an immediate loading on it. I just cover everything up. This is after 10 days. And what is great with the Beta TCP, it's after that you have always a very nice pinkish tissue. It's really great. And it's increasing also the thickness of the connective tissue. You will have a gum that is thicker than the one that you did have previously. This is great because of that too. And so you see on the CBCT after 6 months, this guy was going to Caribbeans during the 6th month of the year, and in France the rest of it. So I saw him when he was in France. He went to Caribbeans for 6 months, and when he did come back, I just do the uncovering of the implant. And I did the CBCT in the same time, and you see the bulk of the hard tissue. I will show you here. You have a nice bulk of the hard tissue. You have all the hard tissue here too. All this area basically is protecting your implant because it's all in the buccal area, and you have the implant placed more palatally, but I could not twist it a lot because, I mean, you cannot angulate it a lot. If not, I will make a windows just right here. Also, I want to avoid to do that. Also, it will be a cemented crown on it and not a screw retained one. Next one, just 10 seconds. That's it. What you can do also is covering up with the SSA. It's called a socket sealed abattement. This has been developed by a French dentist and surgeon called Dr. Gary Finol. And basically it's to make a healing screw, but homemade, to be able to cover the emergence profile of the implant. And this works really well. And it works even, it has to be when your ISQ is over 70, but it's working fine because you have no stitches. Also, a broken tooth, and the tooth is broken just right here, like that. Also, we remove the tooth, we osteodensify the area to be able to have the primary stability. This is very important, like that you will have, when you have primary stability, you will have osseointegration. This is for sure. Also, when you have to have less 140 micron mobility of your implants. Also, the higher your primary stability will be, the better your osseointegration will be, and the quicker. What we place the implant just right here. No flap. I never do flap when I'm not obliged to, because I mean, like that, it's the wound cover, it's the wound just closed. And when the wound is closed, you have less risk of infection, you have less risk of bone loss, and basically you are in a situation that is nicer and better. I placed all the graft that I need to be able to fill up all the socket, and the SSA just on the top of it. And the SSA, as you see, is done with the composite, that flow composite, and is just basically give you the emergence profile of your future implant, of your future crown, sorry. Also, it gives you the emergence profile. You keep basically your emergence profile of your future crown. And this is really great. And you can reproduce that all the time when your implant is stable. After a couple of months, you still have the nice gum all around, and you will be able to do the prosthetic work. Check the secondary stability. Always I'm checking the secondary stabilities to see if my implant is well osseointegrated. 79 rolling, it's okay. And I take the emergence profile using light composite flow 1. I place it, I take the regular impression, and you have the PFM crown. This is a must be, yeah, this one is a PFM crown on this T-base placed, titanium based. And we'll show the same one with the little movie that I did, and you will see how does it work in the real life. Also, a tooth is broken. I remove the tooth gently, as gently as I can. The stain, the surgical stain placed, the pointer. I'm getting after my osseointegration, my osseodensification drills from Versa. Like that, I would gain in the primary stability and bone densification, and in the same time, bone expansion. Like that, I have my bone expansion. It's a lot of water because, I mean, we just try to avoid to overheat it. Placement of the implant, it's an avant-garde, 3.75 by 10. I check the angulation. This is great. It's in the palatal area. The ISQ, 70-70, the graft. And you see, I use it like a pocket. I push all the iceberg that I can inside, and I press it with like that. I press to the gauze to be able to push as much as I can inside. The more you place, the better it is. We clean everything up like that and more. I will end when all will be filled, and I will have all the beta TCP inside as I can. Also, it's a bit messy because you put it everywhere. I mix it with the antibiotics, metronidazole. The placement of the composite on the top of it. I'm gonna cure it in the first time. I'm curing it a couple of times in one side, in the other one, to be able to have nice hard composite on the abutment. You know, you have to be careful and just avoid the contact point to be able to remove it, because if not, you will not be able to remove it. This tricky sometimes when you begin with, because it's difficult to just make it flow just in the right position. And I remove it, that's it. I will clean everything up, replace some composite in, polish it up, and back in. And like that, all your socket is basically covered and your emergence profile is maintained, and you will have the emergence profile of the previous tooth to be able to do your crown when you finish it up. Yeah. What you can do to maintain your soft tissue and your hard tissue in the same time, but mainly your soft tissue, is to use partial extraction socket shield. That means that you maintain a part of the root into the buccal area. And this worked really fine when you see this area, when you have a problem with this tooth. And I would cut off, I will show you by drawing. I would cut off basically just right here at the level of the bone and remove the bit of the buccal area underneath from 1 millimeter to half millimeter. You will have this area is underneath the bone. Okay, this is a part you will have to avoid to keep the. You have to remove the apex of the tooth. If you don't do that, it doesn't work. So what I'm doing, and here I will have the socket shield just right here, maintaining like that, and I will place my implant around here. Like that, I have at least 2 millimeters from my socket shield, and the socket shield just is here to my implant here. You have to have 2 millimeters. If not, it's working. It's not working well, because I mean, if you are placing your implant close to the tooth, it's not a good idea. I will show you the result, because I mean, everything is, that's it. Here we go. Here you have the tooth. Yeah, oh, sorry. No, sorry. Here we go. Here you have the tooth. We can see it here. Your implant is 2 millimeters away from, because here you have the abutment. It's not the implant, because the abutment is a bit wider than the implant. And you have 2 millimeters between one to the other. You fill everything up using a beta TCP everywhere. You push it, you have, and you see what I said, your primary stability is really a bit low, but I mean, the patient didn't have a contact in these front teeth of 4 or 5 millimeters. Also, I didn't have a problem to place a temporary right away, because I mean, the anterior teeth didn't touch at all. Because of the swallowing, kids swallowing, just placing the tongue between the teeth when just swallow the saliva. So I didn't have the problem to place, but I mean, it's too low for a regular case. So I would avoid it to load it for if the ISQ was lower than 70. But this case was a bit different. Also, I placed the temporary. This is after 6 months. You see that the temporary is aging, but I mean, the gum is great, and the level of the gum is great too. And you see the emergence profile, how it's nice and how it's thick, and just keeping the root just keep you the gum on the buccal area. And I will show you the practitioner who did the crown, because I didn't do it. Up. No, I just show you the emergence profile. I didn't have the crown on this one, but you have nice emergence profile. I can send it to the referral to be able to have the crown done. Another case, and you see that it's no way to have a screw retain crown, except if you have an angulated screw. But I mean, that's it. It's the only way that you can manage a screw retain one. Also, what I do is in this type of cases where the angulation of the implant of the ridge, it's too different, according to the. I will show you here. It's no way that you can place an implant right like that, because I mean you're gonna go to the buckle. Also, you can have even a screw retain with a specific type of screws, or what I like better is to have a custom abutment, and on the top of it I cemented it, and it's working fine too. Going to the simple, also extraction. Same way, I'm taking to the right, you have lower right, you have the extraction. After in the middle, you have the space that I do to be able to place the graft. And to the lower left, you have the connective tissue into place. And like that, you will have the amount of gum that you need for a nice restoration. Look at that. After 10 days, you see the bulk of the gum that you still have. And it will increase, because I mean, basically it will smooth, but it will get thicker too in the same time. So it will get really natural. After 3 months, look at the amount of gum that we have. We have a nice emergence profile, and we'll be able to do the crown. You see zirconium abutment, custom abutment, and at the top of it, I cement an IMAX one. And like that, I have a nice emergence profile, and in the same time, I'm preserving aesthetic. All are GMI implants. I'm just placing for 7 years now, more than 6 years, GMI implant, and it's really great at all. Also, into conclusion, what I can say that you have to manage this in prosthetics, in post-extraction implant, immediate post-extraction implant. To success, what you have to have is soft tissue, the bulk of soft tissue that you need. You have to have hard tissue, and basically the best is to place your implant in the native bone, because native bone is maintaining your biology. And when you maintain your biology, you will not have problem. All the grafts are pancaking. And if you still have a problem down the line, you will have your graft, which is gonna go away as quick as you can believe. Because I mean, if you have even a beginning of the infection in the graft and you place an implant, or you have a patient which is biting on something and you just put a piece of food inside between the stitches, your graft will flow, and you will lose all the most of the graft that you placed, even if it's after 2 or 3 months. You have, as you can better to place your implants in the native bone and maintain your native bone by grafting. This is really the best way to go, and the way that you get with whom you're gonna get quiet and nice, and you can reproduce it for all your patients. Also, placing the native bone is the best way that you can do the stuff. Adding soft tissue or maintaining the soft tissue by different way, by partial extraction, or also by SSA, just covering the shield, covering with the composite on the top of it, or all the stuff that I show you, just to maintain your soft tissue and just cover your hard tissue. And don't be so strong when you cannot be, when you have an angulation of your crest that is too your ridge is too different according to the angle of your prosthetic restoration, cemented in, or use different type of screw. But I mean, I don't like too much the funny stuff, because I mean, when you do this screw angulated one, you have oftentimes unscrewing, and GMI do not unscrew. The avant-garde do not unscrew also. I'm pretty confident on them, and I just screw the abutment into place and place a crown on the top of it. Hard tissue maintaining by grafting. Also, you can use sticky bone, you can use beta TCP, you can use other stuff. Usually I like to have resorbable material, because I'm pretty confident that when the resorbable material, it's gone, you still have bone. And if it's resorbing and you have nothing, that means that you don't have bone. The fact is, resorbable, you must assume that your bone will be there in a couple of months. Also maintaining the heart tissue, just avoiding socket closure. Doesn't need to be closed. Also place hemostatic sponge, place connective tissue and the hemostatic sponge on it, and increase the attached gingiva, because I mean, when you place connective tissue and you do not close the wound, you will have the clot will be done in after 12 hours, and after 12 hours you will not have any problem. You just say to the patient to not bite hard stuff for a couple of weeks to try to avoid it, avoid the area, and like that, by not closing it, you will increase the amount of, you're not destroying the attached gingiva, and you will maintain the amount of attached gingiva. And this is really important for the pink. Implant and surgical part is the implant is a surgical part of a prosthetic work. What is giving the impulsion is the prosthetic work, and you place the implant where you need your implant to have a nice crown on the top of it. And this is for a long time. I mean, it's more than 20 years that we don't see, I place the implant where the bone was and you're gonna try to have a crown on it. I mean, that is finished. We don't do that anymore. But sometimes the angulation of your ridge is a higher discrepancy, because between your angulation of the ridge and the angulation of the crown also is no way to have a screw retain implant. Crown, sorry. Also, what you have to do is cemented it or having angulated type of apparatus to be able to place, if you want to have all the time, you're stubborn and you want to have all the time screw retain, so you have to use different apparatus to be able to have screw retain, but it will be not in the angulation of the tooth. And this, you have to be aware of that, and we cannot do anything about it. And as this is closing my presentation about post-extractional implant placement, I hope that you did like it, and I thank you very much for being here today. And if you have some question, I will be glad to just answer it.
Hello, thank you, Laurent. I don't know if you can hear me. We are having.
Yeah, I can.
Okay, fantastic, fantastic. So we had a little issue at the beginning of the presentation, but now it's solved. Thank you very much, Dr. Bluche, for such a clear and practical presentation. I guess some people may have some questions. Ideally would be to place them in the chat, so you can place your question in the chat, but if necessary, we can do it in an open, by voice, in opening to everybody. But I think doing it in the chat is a little bit more organized, more well organized. So I don't know if somebody has a question for Dr. Bluche. Maybe Amrendra. So I'm receiving in the chat. We are receiving some. Yeah.
Can you hear me?
Yes. Then I have another question from Pierre K. So tell me, Amrendra, please.
Yes, sir. On behalf of GMI India, I would like to thank Dr. Laurent and Mr. Dominic from Spain for a wonderful lecture. And I'm Dr. Amrendra.
I have a question there. I can read the question. What graph to use after placing? I still have a question on the chat, just right here.
Yes. But Dr. Amrendra wanted to thank you. Is the general manager of GMI India.
Okay,
sorry,
thank
Amrendra.
You. Okay, I'm sorry.
So I would just like to say that thanks for the participation. It was a overwhelming response did we get, and we will continue to do so in the coming future. And as for GMA India, I would like to say that it is one of the best companies in Europe, and we are the direct subsidiary. So if there is any inventory, there is no inventory so as such. And as you've seen that Dr. Laurent is using one past more than 6 years, and he is really satisfied with that. So in the future, we're looking for a rewarding response from in all of the doctors. So just I wish to say thanks again to everyone. And then we will now conclude to the questions. You can ask questions to Dr. Laurent. Thank you, everyone.
Thank you very much.
You have certain questions, Dr. Bluche.
Yeah. What graph do you use after placing implant in the interradicular area? So when you do a septum expansion, basically what I'm doing, and I'm placing beta TCP all around. So basically I have my implant into the septum. I use Versa for a bone expansion. I place the implant between, and I just fill everything up with beta TCP. And usually, if my primary stability is great, I'm just placing an SSA. That means that the screw homemade, healing screw homemade on the top of it. And like that, I maintain all my graft. And if I cannot have the primary stability, basically I fill everything up, place a hemostatic sponge, and I just suture it. And after 1 week, the closure is done, and you don't lose the attached gingiva. Another question from Dr. Sunil Tron. Can you please elaborate on socket shield technique? The socket shield technique is really easy, as I show on my presentation with the little movie. I mean, basically you place an abutment on the implant, and you basically fill on the top of the graft the composite flow on it, and you light cure it. When you remove it, you have some granules that just get stuck into the composite, and you remove them. You just fill this composite with this hole with the other composite that you light cure, and you polish everything up, and you place it back in. I hope that I'm clear on it. Sir, what you place, Dr. Swampnil Sagar. Sir, you place composite on the abutment. Yeah, it's on the regular abutment that I place it, and I place it directly on the abutment. It's just basically stick on it. When placing extraction of a lower first molar. When planning extraction of the lower first molar, we wish to place implant in native bone. Then if you find to keep wall of the implant around the socket, usually you have the septum just right in the middle. If it's a lower first molar, and if it's a lower first molar, you have a septum between, and the septum, what you do, you expand the septum using reverse osseodensification drills like Versa sell them, and basically you have your implant in a native bone, and you place your implant just right into the septum, and after you graft to maintain your native bone. Sir, so Arun R. Sir, you did composite to shield the graft in the last case. Yeah, it's called socket shield abutment, and basically is something that you place on the top of the graft to be able, in one hand, to keep your emergence profile of the crown that you extract, and at the same time to cover everything up without stitches. Dr. Azif Hallery, what are the contraindications for socket shield technique? The contraindication basically of socket shield technique is to not have the primary stability. If you don't have enough primary stability and your ISQ is less than 70, you cannot have a socket shield, because basically more or less you charging, I mean you loading a bit your implant. Also you try to avoid it when the primary stability is not there. Haren, do you do immediate loading in single implant after extraction? Yes, I do, but it's not immediate loading directly. Is a temporary immediate loading, and usually on the single implants to the premolar, and that's it. No back. Also, I'm placing from the central, the canine, first premolar, but I'd avoid the rest of it. Aaron R. So no membrane. I'm assuming I'm doing that for 10 years now. It's no placing membrane. Even when I place sticky bond, I place no membrane. I just avoid to place membrane, and I just use membrane only for sausage technique, when you need to have your graft basically trapping something by the time that is getting into the bone. I mean, is changing into bone. So if you don't need membrane at all. And it doesn't make any difference, because membrane increase the inflammation. Also, you are losing a bit of your graft when you use membrane. The only time that I place membrane is for sausage, when you need to keep everything together, and like that, membrane helps. I hope I'm clear. Brie J. When placing implant in immediate socket, another one. When placing implant in immediate socket, molar stability is low. How close the socket? Okay. When you have the immediate placement of the socket and the primary stability is low, you don't place SSA on the top. What you are doing is just fill it up with the graft. After that, you place a hemostatic sponge and you suture the hemostatic sponge on the socket. The hemostatic sponge will take 1 or 2 days to just come off, but I mean, by the time your graft and the blood will just make a clot together, and it will not be removed. Also, what's gonna happen is gonna lose some granules, but I mean, the rest of the graft will be into place. Brie J, one more time. Do you recommend using collagen plug or cytoplast to use in the cytoplast to use in the molar socket? No, you need to have some beta TCP. You need to have some graft if you place the implant in, and after you can place a hemostatic sponge on the top. You use a socket plug only if you don't place the implant in the same time. What the accurate position of the implant when the create the bone in the case of PET? Breast extraction and treatment. What the accurate position of the implant? The accurate position is palatal for the maxillary, because I mean, the palatal area, it's nice because you have a thick connective tissue. Also, if you place on the palatal area, you will be always quiet. And like that, in the same time, you have the easy area. I mean, you will place easier screw retain prosthetic work. I mean, how deep? Okay, sorry. So how deep you place it? Usually in post-extractional, I'm taking from the ridge of the buccal, the ridge of the palatal or the buccal, the palatal or the buccal and the lingual, and I'm getting minus 1.5 millimeter underneath. Also, I take my probe, I place it between the two area of the socket, and I place the implant lower to 1.5 millimeter underneath. I hope now you have the answer to the question. I think that it's the end of the question. I do not have any more.
I think so. There are no more questions. I really strongly recommend everybody to take advantage of having Dr. Bluche with us to make additional questions if necessary. In any case, you all know that we will send you the link with the video recorded. You will be able to see it as many times as you wanted, as you want. There is another question, yes.
Same in immediate and delayed placement. Yeah, it's the same, basically the same. The difference between immediate and delayed placement is in delayed placement, you always lost 1.5 millimeter. Also, basically, you will take it 3 millimeter lower than you will place it if you do post extraction directly. Also, it's why we gain immediate post extraction implant placement is gaining bone, because I mean, like, when you will gain bone and you will avoid to have the loss of the bone of the first 3 months. Also,
yeah. And one more point, as Dr. Laurent answered to a question by Dr. Asif Alari. Suppose if you're placing a frontal implant, then it has to be placed at the equicrystal level. And suppose you are placing an implant in avant-garde or any other connections, then you may try to post it around between 1 to 1.5 mm. So I think for frontal, you have to be at equicrystal. Am I right, Dr. Laurent?
right? I like narrow type of implant. Is what you are talking about?
Yeah, I'm trying to say, if we are using, we have different brands. Suppose if you are using a frontier brand of GMI, then it is better to place at an equicrystal point, because it has internal hex connection. So equicrystal, like 0.1 mm beside the bone, that will be the perfect position.
Yeah, I mean, it's depending. I mean, everyone use the type of implant it does like, and if you want to use an external, I mean, an internal X, or if you want to use a press fit one, it's okay with me. I don't see no difference. Whatever you do, you use. I have the use to place avant-garde one for a long time, and it's why I'm just sticking on it, because I mean it's getting fine with me. But if you can do in the same one with the internal X, it doesn't make any difference.
Okay. And one more thing, like suppose you talk about the hostel. Suppose in the case of the primary stability, you got a D1 bone where the Houston units is more than 1,000, and you get a D3 bone. In both, if the quality of the hostel shows a number 70, so would you devise different strategies for D1 when where the hostel is 70 for immediate loading I'm talking about, or for the D3 bone where the hostel is also 70? So what is your opinion about that?
Usually I'm taking the ISQ, because I mean the ISQ, when I'm over 70, I can load it. And when I'm under 70, I try to avoid it, because under 70, you're not in the area where you will be sure that you will not have a primary micro movement, and also having a fiber integration. It's why I'm checking the ISQ. And when the ISQ I have 70, I know that I can place the implant. I can place the temporary crown on the top of it.
So you mean to say the Houston units or D1 or D3 doesn't matter a lot. If you get ISO level, even in a D3 bone or D4 bone, you can place, you can think about immediate loading.
Yeah, you forgot one thing, that I'm using also the densification drills. Also, that means I'm transforming D3 in D2. Also, I'm increasing the double of primary stability by osteodensify the bone. And it's why Versa, the reverse drills that I use for expanding the bone, increase my primary stability. Also, the density of the bone to begin with, I don't have any problem with that, because I will finish up with the bone, dense bone. You know what I mean? I'm increasing the density of the bone by using osteodensification.
Okay, I got the point, because I think that can be done with the design of the implant also, and with the denture bar also. That is a possibility. And
Mhm.
and one more thing I would like to ask, suppose we are placing a lot of GMI. So what is the minimum like time of loading? Within 6 weeks, or what is your experience about the GI? Do you mostly go for the immediate loading, or do you wait for 6 weeks and suppose it on 4 cases
I cannot
or
hear
all on
anything.
6 cases?
Can you write it up? Can you write it for me? Because I cannot hear. I have other microphone in the same time. I cannot hear anything. Can you write it down? I can explain it, because I cannot hear it. I have a couple of microphone open in the same time. I have Ramita. If you're having a buccal bone loss while extracting the image to the immediate placement, yeah. Also, basically, if they have the loss of the buccal area when you extract the tooth, basically you can have a loss of the buccal plate, because most of the teeth in the maxillary are buccally placed. Also, oftentimes you don't have the buccal. Also, what you do is to get in the thickness of the palatal and giving a bone expansion using specific drills to be able to have a primary stability and place the implant in the native bone. And after that, you just feel like a bag. You feel the rest of the socket to be able to graft it and giving the bulk of the graft. And like that, you have your implant placed in the native bone, and by the graft, you maintaining your native bone. I like a flapless one. And other from Mihak. Is flap technique preferred in delay implant placement? Flapless technique, is flapless technique preferred in delay implant placement? Flapless if the ridge is thick, but I'm just wondering to not having windows in the buccal area. And when in the post-extractional immediate, I can see that I have no problem in the buccal area. So it's why it's safer for me, because I have the vision without opening a flap. Which company of osteodensification kit do you use? It's Versa, V-R-E-S-A-H, Versa, like vice versa, from United States. It's Dr. Salah Uez, who just is the inventor. Mihak, what is the difference between the implant provided by GME and another brand such as Dentium and Straumann? The difference is first, in fact, the use is as easier. The use is for prosthetic work, very easy, because you don't have multiple abutment that you don't need, and you don't have multiple screws that you don't need either. And basically, you can standardize your type of treatment. And GMI never unscrew. I mean, it's really rare. And screwing of GMI is rare. Also, and Straumann has been in first, but Straumann doesn't have primary stability. So the stromai tissue level, the primary stability is not really great. And in the same time, the price is not the same too. Also, often you can use a standard, same level of quality for a much more easier price to deal with. Amrinda Kumar, time of loading, 6 weeks or more. The time of loading is usually I'm used 3 months, also is 9 weeks around, no, 10 weeks. 10 weeks, something like that. I like 10 weeks because now I'm sure that after 10 to 12 weeks we are okay, and 3 months is my loading time. Haren, I'm placing flapless implant. Don't you push in the gingiva while drilling? A flapless implant I'm not using a lot. I'm just always open a little bit in the ridge area to be able to get the bone. To be able to have to be able to see the bone. I'm not using pusher. I'm not using all that stuff. I'm just getting to the bone. And when you remove a tooth, I mean, you basically direct it to the bone. You clean everything up and you are in the bone anyway. Dr. Asif Alari, what is the fate of shield and will grow between implant and shield? Should the gap be grafted? Yeah, the gap has to be grafted. Also, basically, what you do is you graft it to the level of the socket to fulfill it totally, and you place your socket shield on the top of it. Also, you don't have space between your graft and the socket shield. Thank you. What should be the extent of tooth structure apically for the socket shield technique? Usually it's 5 to 6 millimeter of the tooth. Is the question of Dr. Sunil John. It's 4 to 5 millimeter that you leave for the socket shield. This is great. 5 millimeter to 8 millimeter. It's great to be able to socket shield. What should be the thickness of CT graft? This is Dr. Deepak, as much as you can. So if you get a good thick connective tissue that you get from the tuberosity, and you can get into tunnel inside of the buccal area, place it. You can reshape it after with the burr if you have too much, but it's really rare that you end up saying, oh, I did place it too much. Also, the most that you can fill in, do it. Wishu Gadok. Why doing flapless implant? Can we start with the biopsy punch? Why doing place against you can end up with a punch and you start the drilling after. You try to avoid to not have the thickness of the gum get directly into the bone structure before getting your first drill. And I don't use flapless. I'm basically on the post extractional. You have already the hole done. Also, I'm not using a biopsy punch anyway. Donc I cannot give you the brand that you can use. Dr. Atab Mirza. Oops, I forgot up to. Immediate loading case for full mouth implant rehabilitation. How many implants in the arch are recurring minimum on this type of prosthesis? Also for the all on 6, it's 6 on the maxilla. You can slow it to 4, but all on 4, it's a bit tricky according to the long lasting. I will say 6 in the maxilla and 4 in the mandible. To be able to have immediate loading. Dr. Asif Alari, thank you. Thank you very much. Dr. Aftab Mirza, if zirconia or titanium material used for the prosthesis, so it's depending upon what type of prosthesis, if I use zirconia or titanium. zirconia, I will use them for a single or a couple of restoration. But if I do a all-on-6 or all-on-4, I would like better to have a metallic framework, because I mean, with the zirconium, we have a problem of wave. Due to the zirconium can impact the implants. Also, I like to have a break between the crown and the implants, as in mostly using a metallic frame. Dr. Sunil John, do you recommend all on 4 or all on 6 with GMI implant? For sure. I didn't talk about that, but I still have plenty of cases to show you. All on 4 and all on 6 with GMI is really great, and especially with Frontier. Frontier develop a lot of different type of MUA multi-unit abutment that you can use. Very low transgingival one, higher depending upon of the thickness of your gum, and this is great to place all in the same level to be able to load it nicely. This Frontier is basically the choice for the all-on-6 or for the all-on-4. I would recommend Frontier for that. And I think it's the end of the question.
Yeah, I think there are no more questions. It's been really, first of all, a very interesting presentation, but also after that, a very good post-presentation discussion with a lot of questions and doubts that have been clearly explained. And that's what we are looking for. So everybody discussing and learning new things. Yeah, I would suggest to have to be the last one, because we are a little bit.
The last one.
Okay.
Sir, you told that the socket shield, there should be 2 millimeter space. Then how can we immediately load it? Yeah, you have 2 millimeter space at least between the socket and the implant. That means that your implant in the palatal area also is basically placed into the palatal area, and your socket shield in the buccal area. And because of the fact that you expand your palatal area, basically you have the implant into the bone, and you have the implant into the bone, a space, and the buccal area where you have the part of the root. And like that, you fill everything up with the graft, and you place your temporary crown on the top of it. I'm sure that okay now. It's no question anymore.
Okay, I would like to really thank you, Dr. Bluche, for such interesting presentation. There is another question yet.
So as the sometime in cyst area in anterior we find it difficult to place the implant. Yeah, because when I show it with the apicoectomy that just didn't end up well, you can take with the osteodensification, getting to have a groove done in the buccal, in the palatal area, and also in apical part. You just get 2 or 3 millimeter you still have to be able to lock it. Also, you have all the groove in the palatal, and at the same time on the apical area, you have 2 millimeter to be able to have your primary stability on it. I think it's closed.
Yes, thank you, Dr. Bluche. Thank you all the attendants.
Thank you very much.
I just want to remind you that you will receive the link to download the presentation and to review and see again the video. Thank you, Dr. Amrendra from GMI India, for the organization, for helping us to organize it. And please, I strongly recommend you be attendant to your email, because we are going to organize new meetings very soon, and you will be very welcome. Thank you from on behalf of GMI Group. Thank you all. Bye-bye.
Thank you very much. Bye-bye. Thank you very much.
Thank
Bye-bye.
you, everyone. Thank you.
Bye-bye.
For any confusion.
Bye.
Bye-bye.